Hello, good morning, everybody. Today we are going to talk on a very important topic of surgery, which in any examination which have got a multiple choice questionnaires, a peripheral subject of the syllabus means the surgery. You talk of the GIT, and in GIT it is the piles and your carcinoma colon or the CA rectum or CA stomach or carcinoma pancreas and pancreatitis, and all those they are the very main content of the surgical topics in the GIT chapter. But in any competitive examination, the setter or the group of setters, what they do, they take out and catch the peripheral most subjects which are touched very rarely by the students, because the student thinks that it is not that important and tries to cover the major chapters, the big chapters. No, I will suggest you that do give due importance to the smaller and rarely asked or rarely occurring disease chapters. And one of it is the colonic diverticulum. So, what is colonic diverticulum? So, the colonic diverticulum, number one, what is the diverticulum? Diverticulum is nothing but a herniation or the outpouching of the colonic mucosa and its adjacent connective tissue. So, it is the kind of herniation through the musculature of the colon, and this musculature or the herniation through the musculature occurs along the tinea coli. Now, what happens? The local colonic muscle and the mucosa, because of a mechanical irritation, becomes thickened. Anywhere in the body, nature tries to limit or localize the problem, and in doing so, the muscles become thickened, the mucosa becomes thickened, and maybe little bit of fibrosis occurs. Now, the peak age of occurrence of the diverticulum or diverticulosis or diverticulitis or the colon diverticula is the 50 to 70 years of age. It increases as the age goes on. We are starting getting the diverticulosis. And why it occurs? Because the intramural pressure within the gut, especially the colon, increases, and the content of the colon tries to get away. And in getting such a way, it herniates to the musculature and causes the mucosa, submucosa, and the adjacent subcutaneous uh, connective tissue to form a pouch, and this becomes a outpouching of the colonic mucosa and its connective tissue, and this is what called the diverticula. Now this is okay, this is a fact. Now this is the acquired form of the diverticula. There is another, in contrast to this, there is another form of diverticulosis, and that is the congenital, where all the layers of the colon is present in a POW, in that particular diverticulum. If you take a histology, it has got a serosa, subserosa, musculature, serous layer, visceral layer of peritoneum. So all the layers are available when there is a congenital variety of the diverticulum. But here it is the acquired form, so it lacks the muscular tissue and the other tissue, but it has got a mucosa and its adjacent connective tissue. So this is the key fact. This must be known to us when we are talking of the colonic diverticula. Now we come on to the clinical features of the colonic diverticula. So there are three varieties, although you call it four varieties of the situation. One in one form is the asymptomatic. There is no symptom, as the word says, it is asymptomatic, and this group is found incidentally. The patient is not aware. Even the doctor is not thinking of it because the presentation is something else for which the patient has gone to the doctor. Okay, now the second variety of the colon diverticulum is the painful diverticular disease, in which you have got a repeated attacks or episodes of pain, fever, nausea, vomiting, and so on so far. And the third variety, which is very, very important, and that is the acute diverticulitis. Whenever, as a medical student, you know whenever there is a itis, that means the inflammation or the infection. Okay, so acute diverticulitis is a very acute condition, and the patient presents to the surgeon with fever, nausea, vomiting, pain in the left lower quadrant of the abdomen. Then the third or the fourth variety is the bleeding diverticular disease, where the patient finds one sudden night morning, he visits the laboratory, he finds that his stool has got a dark red clotted blood mixed in the stool, and he is frightened and visits the surgeon, and the surgeon does all the variety of a tool of investigation, and then with the help of the barium enema or with the colonoscopy or with the endoscopic photography, he is able to know that there is a diverticula which is having a ruptured blood vessels and causing the bleeding to occur. So these are the four clinical features of the variety where the diverticulum can present. As I told you, asymptomatic cases, hardly there is anything. The patient is asymptomatic as far as the diverticulum is concerned. The patient may have something else. He may have a loose motion. He may have pain and nausea and vomiting and pain in the right iliac fossa. So he may be having a appendicitis. But because of something or other, the barium enema or a colonoscopy or a CT or something is done, and that reveals that the patient has got a diverticulosis also. So that is an incidental finding which has nothing to do with the presenting symptom. So that is the asymptomatic cases. Now, the second variety of the diverticular disease is the painful diverticular disease. In this, the patient has got left lower quadrant pain, because the situation or the most important significantly involved part of the colon is the sigmoid and the descending colon. So it is the left side which is and the lower quadrant which is involved. So the patient has got a pain because of the outpouching or the diverticula is inflamed, and when this occurs, it is found in the literature that the irritable bowel syndrome is usually associated. Since the left lower quadrant pain is occurring repeatedly, either it becomes the nature of the patient or it is the irritable bowel syndrome which is causing the pain. Now, it is difficult to isolate the diagnosis for which the pain is there. So, a painful diverticular disease. The third one, which is the most important as far as the surgeons are concerned, and that is the acute diverticulitis. Here, it is the sudden onset of pain, fever, loose motion, nausea, and sometimes vomiting. Left lower quadrant pain, I told you it is the sigmoid and the descending colon, and hence it is on the left side and the lower side. In this, there is a very high fever and the patient is having a terrible pain in the abdomen. And for this, the patient visits to the doctor or the surgeon. Now, the fourth one, or in the third one, if you see the clinically, as you see in the right iliac fossa, there is a tenderness and McBurney's point, and you diagnose that the case is a a case of acute appendicitis. Similarly, here there is a left lower quadrant tenderness. Patient has got a tachycardia, and if by chance the patient goes to the OT and a surgical resection is done of the diverticulum, and if you take a histology of that, histopathology of that, and then you find that the subserosal area of the pouch of the diverticulum is having a neutrophilic infiltration because of the inflammation. So this is the clinical presentation of the acute diverticulitis. And the fourth one, which is important and frightening to the patient, is the spontaneous onset of the bleeding. And the patient finds that his stools are having dark red blood which is clotted. And as far as the symptoms, there is no prodromal symptoms. Earlier, the patient was perfectly all right. All of a sudden, in the morning, when he visits the laboratory and he finds that the stool are having dark red clotted blood in the stool, and he's frightened. And he visits the surgeon, and he does all the investigations to rule out the stricture and the carcinoma, and he tries to know the know the bleeding varices or the bleeding piles or something. And when he does a endoscopy or he does a colonoscopy, he finds it is the peridiverticular submucosal blood vessel which are ruptured and is causing the bleeding. So it is a very frightening situation because blood means alertness to the patient and to the doctor. Otherwise, the chronic bleed in the gut leading to the anemia and other complications. Now, as far as diverticulum is concerned, what are the different complications can occur because of its presence? So, in the presence of the multiple diverticulum or the diverticulosis, a pericolic or a paracolic abscess can form because it is very risky for the diverticulum to have an infection. It's very common, can occur. The flora of the gut and opportunistic infection can occur. And when the paracolic abscess bursts, it can lead to peritonitis. It can lead to diverticular fistula when there is a draining of the abscess and the adjoining structure may get infected and form a fistula. And then you may have a stricture formation because of chronic constant inflammation there within the colonic area. There is formation of the fibrosis and the lumen becomes narrower, and ultimately there may be a complete blockage, and that is called the stricture formation. So this is the main four complication of the diverticular disease. So the paracolic and the pericolic mass or the abscess can form because of the infection. Acute diverticulitis can turn into a colonic pericolonic abscess or a mass, and this abscess is formed and giving rise to the fever, tachycardia, and unresolving abdominal pain. And if you examine the patient and if you palpate the patient the abdomen, you find the left lower quadrant mass. As you see, the appendicular mass is seen. Similarly, on the left side, you find a pericolic or a left lower quadrant abdominal mass, and that is the thing because it associates with the fever, tachycardia, and pain. It is 90%. It is the case of a complication of the paracolic or a pericolic abscess of the diverticulitis. Then you have got a peritonitis. Now, if the pericolic or the paracolic abscess or the mass, if it gets infected and it bursts within the peritoneum, it leads to suppurant peritonitis and can cause clinical features of the fever and the severe abdominal pain and generalized guarding and the rigidity of the abdominal muscle abdominal wall. So you will come to know that now the patient has got a second complication of the diverticulitis, and that is the peritoneal. That is the patient has got a secondary complication of the diverticulitis, and that is the peritonitis, because of the perforation and the drainage of the paracolic abscess in the abdominal cavity, and there is the peritoneal cavity, and the peritonitis ensues. Then sometime the mass, the paracolic abscess perforates and drains adjoining into the adjoining structure like bladder, because it is lower quadrant. Bladder is very in sigmoid colon, and the bladder they are they are neighbors. Similarly, the sigmoid colon and the vagina, they are the neighbors. So if the mass develops in the sigmoid colon area and the mass perforates, suppurates, and drains, and then this drain occurs or involves the adjoining structure, there may be a formation of the colovesical fistula or a colovaginal fistula, which needs which needs a surgical treatment. Then I told you the if the repetitive diverticulitis occurs again and again, so it leads to the fibrosis and the complete blockage of the lumen of the colon, and this colonic structure is nothing but because of the repeated colitis, pericolic diverticulitis. Okay, so this all can lead to the stricture formation, can lead to the colic abdominal pain and distension and the bloating, and the patient is having vomiting and nausea and restlessness. So now how to diagnose the colonic diverticulum? So the double contrast barium enema is the gold standard to diagnose the colonic diverticulum. Is gold standard. Barium meal, whatever the MRI, the CT, the PET, anything cannot replace the Perian enema. It's a gold standard till now. So the colonoscopy is done just to rule out, because the mass is there, na? So to rule out that it is not a carcinoma or it is not a tumor or it is not something else. So colonoscopy becomes a must to rule out, not to diagnose, but to rule out the tumor and malignancy. Then a routine blood examination like the complete blood count, the hemoglobin level, the ESR, the C-reactive protein has to be done, because you don't know when a case has to be taken to the OT anytime. So a routine blood investigation should be there, and you must know what are the different counts. That also helps you in knowing the prognosis, the ESR, the CRP, and the count that leads to estimate or evaluate the progress of the disease or deterioration of the disease, whether the patient is improving or deteriorating. And accordingly, you can take the step whether the medical treatment or the conservative treatment has to continue or a surgical step has to be taken. So routine blood examination, don't take it lightly. It's a very, very important an investigation and a tool for the acute or any condition of colonic diverticulum. Now the treatment part, you have got medical treatment, you have got surgical treatment. So medical treatment means non-surgical treatment. There is no cutting business. Surgical treatment means there is cutting business. That means you are going to resect the diverticulum. And in case of the medical treatment, it is the high fiber diet and the plenty of fluid is given, the stool softeners are given, and this all to decrease the intraluminal intracolonic pressure. So when the pressure inside the gut colon is decreased, the diverticulum gets a rest and is not on pressure. And number two, you have to use the IV antibiotics. A combination of the amoxicillin, metronidazole, and the gentamicin usually suffices in acute situations. In the recurrent diverticulitis and in the diverticulosis conditions, a need of 6 weeks of oral antibiotic is a must. Is a must. So as to eradicate the mucosa of the diverticulum from the infection. Even a small remnant infection will flare up and will give a recurrent episode of the diverticulitis. Then a significantly large paracolic or pericolic abscess has to be trained, maybe under the radiological guidance. Nowadays, interventional radiology is very coming up branch, and the pupil, the radiologist, they are able to drain that abscess through the radiological guidance, maybe ultrasound, maybe CT, or maybe MRI, or maybe anything else. Then you've got surgical treatment. And what is the surgical? Whenever the stricture is there, it needs either resection or a balloon dilatation. Then you have got a fistula. So fistula needs to be treated by the surgically by the elective resection of the diverticulum, and the fistula has to be resected completely, and anastomosis or a repair of the wall of the gut has to be done accordingly. Then in situation where the medical treatment has failed and is unmanageable, in certain situation the diverticulitis or the diverticulosis cannot be managed medically. In those conditions, you need a segmental colectomy, or sometime a operation like Hartmann's resection may also be needed, where you do proximal colostomy and a repair or blind loop of the distal colon. And so this is all about the colonic diverticulitis or diverticulum, and is very important. Is very important subject. One should not miss. One should not take it lightly. One should study. Good is a small chapter, but can give you good coverage on the marking side. So this is all about today's topic. Um, God willing, we'll be seeing tomorrow the new chapter with a new force. Okay, bye bye. See you tomorrow.